Hi, everyone, and welcome to Mostly Harmless Economics, a channel where I catalog and organize interesting papers that I've come across. So today we're going to be tackling the evidence on the historical roots of mistrust in vaccinations and Western medicine in general. It seemed like a very relevant topic, given that the flu season is upon us, and the fact that we are going through a pandemic right now. So this is the agenda for today. I'm going to be talking about two particularly traumatic episodes in history: the coercive medical campaigns that were carried out by the French colonial governments between 1920 and 1956, and another episode involving experiments on Black men in Tuskegee, Alabama, both of which left long enduring impacts on the psyche of the affected populations. So here's the problem. Sub-Saharan Africa has a disproportionate percentage of the global disease burden. The region accounts for 90% of all malaria deaths, 70% of people living with HIV, and has some of the highest under 5 mortality rates in the world. Given the extent of the disease burden, the underutilization of healthcare is puzzling, especially when vaccines are often available and can be used to easily prevent much of the disease burden. Despite this, vaccine rates are often low in this part of the world and are often below the herd immunity rates. So a paper by Lewis and Montero sheds some light on this problem and why this is simply not a logistics issue of delivering vaccines to where they're needed. So between 1921 and 1956, French colonial governments organized medical campaigns in Cameroon and a collection of countries known formerly as the French Equatorial Africa, which consists of Central African Republic, Chad, Republic of Congo, and Gabon, all of which are countries in the sub-Saharan Africa. So the most extensive of these campaigns carried out by the French colonial government focused on sleeping sickness, a lethal disease spread by the tsetse fly. But here's the actual fly in the ointment: the brutal and coercive way with which these campaigns were carried out. So over the course of several decades, millions of villagers were forcibly examined and were forced to receive injections of medications. The campaigns were often forced upon people at gunpoint. And it does not end there. The drug, atoxyl, which was the one that was the most commonly administered, turned out to be of dubious efficacy, with severe and sometimes fatal consequences, including blindness in about 20% of those that were treated, gangrene, and of course, death in worst case scenarios. So you have a situation where villagers were forced to receive injections. Many of the medications had serious negative side effects, and the medications were ineffective. Additionally, the campaigns may have also caused the spread of contagious diseases because of the reuse of unsanitary needles during the campaigns. So what does Lewis and Montero do? They digitized 30 years of archival records to document the locations of campaign visits at a very granular geographic level for 5 Central African countries. And they wanted to explore whether these campaigns in the past can be linked to lack of trust in vaccinations in these places in the present day. Now, when you're trying to figure out the causal effect of any variable X on another variable Y, which in this case is the effect of historical campaign visits on present-day trust, you cannot simply report correlations. You have to be worried about many different problems like omitted variables bias and reverse causality, and so on and so forth. So the authors devise a strategy to circumvent these concerns, and their strategy is a method that is widely used by many empirical economists, and I will have a lot to talk about this in future videos, but for the moment, for this video, I'm going to jump straight ahead to what they find. So what do they find? They find that increased exposure to colonial medical campaigns is correlated with lower levels of trust in medicine today. And villagers in these places are much more likely to be suspicious of freely provided medicines. And the effect becomes larger the more prolonged their historical contact with these colonial campaigns were. This lack of trust translates into a much lower willingness to consent to invasive procedures like a blood test. And it also turns out that World Bank projects in the health sector are less successful in these areas that had greater exposure. So it turns out that a similar story is playing out in the USA as well. So Alsan and Wanamaker explored a particularly unethical and depraved government-run experiment in Tuskegee, Alabama. And these experiments, when they finally came to light, received a lot of media coverage. So from 1932 to 1972, more than 600 African-American men were intentionally withheld treatment for syphilis so that researchers could observe the full life course of the disease. Participants were not told that they had syphilis and they were not given the treatment. The participants had to go through regular physical checkups, blood draws, spinal taps, and eventually an autopsy. Eventually, whistle makers blew the lid in 1972 and revealed the unethical practices of this program. But by that time, many of the men in this study had died from complications of syphilis, and several of their wives and children contracted the disease. So the authors found that the study and its subsequent public exposure resulted in greater mistrust of the medical system by African American men, particularly those living closer to the location of the study. In fact, their estimates imply that the life expectancy at age 45 for Black men fell by up to 1.5 years in response to the disclosure. So this sheds some light on why, to this day, Black patients consistently express less trust in their physicians and the medical system than white patients on average. But there are practical implications of this study with regard to how policies can be devised today to undo this historical legacy. So one of the authors, Marcella Alsan, is both an economist and a medical doctor, which is pretty staggering to me as an economist who's the son of doctors to see my whole family bundled up in one person. So Marcella Alsan, alongside her co-authors Garrick and Graziani, created a randomized controlled trial that involved mobile medical clinics providing free medical services in Oakland, California. They then randomized the race of the doctor to whom each patient was assigned. And they found that having an African-American doctor had a large positive effect on the uptake of medical services by African-American men. These effects were largest for invasive services and among individuals who had little experience with the medical system and who also reported mistrusting the medical system. Thus, by taking into account the historical experiences of African-American men with the medical system, they were able to design a very simple intervention that increased the take-up of medical services. Their findings suggest that Black doctors could reduce the Black-white male gap in cardiovascular mortality by almost 19%. So traumatic episodes in history leaves a big imprint on present generations. And often simply passing reforms is not enough to bring an end to systemic inequities. So as you can imagine, the mechanisms at play here may also be relevant for understanding the persistent inequities that other marginalized populations may be facing in other parts of the world. For example, the indigenous peoples in Bangladesh or the Aboriginal peoples here in Canada. That's it for today. References and additional resources below, and I'll see you in the next one. Thank you very much.